so I have to keep coming over here. So, okay, so let me tell you a little bit about me. So I'm the director of the Center for Transdisciplinary Evidence-Based Practice, CTEP, from now on, right? It's a very long name, but the point of it is we named it intentionally as Center for Transdisciplinary Evidence-Based Practice because that is what evidence-based practice is. So whether I'm talking to nurses or medical residents or physical therapists or social workers or theology majors or whatever it would be, it's the same thing. We teach it the same way. The steps are the same, the thinking is the same, whatever. So we have an opportunity to not do another round of silo kind of stuff where you teach evidence-based medicine, and then when we get to the bedside, we can argue about who got it right, because we're great at that. So that's why we named it that, and that is our intent to always be saying, bring everybody. If we're going to do a class, bring everybody, so we're all learning it the same way. So I'm going to talk today about why it's important. Right? And we'll talk a little bit about what the steps are, but if you really want to learn the steps, you should come to our 5-day immersion, which we do at Ohio State, and it's like a deep dive into the process where you really, really learn it. And who's from Grant? You're from Grant? No, you're from Grant. They just sent a couple people to the immersion. Paula, yeah, she is fired up. She is a wild girl.
She is
and
wild.
she is fired up.
She is. She stopped me in the hallway.
She totally gets this. And she's like, she's one of those people, she left the end of me, she was like, gonna change the world, So she'd be a good person to look back to. But anyway, and lots of people from the James have been through the immersion and stuff like that. But that really is the way to learn the process. We'll talk about it a little bit, but we certainly can't do that now. But how does it fit with all the, how does it fit as an administrator? How does it fit as a staff nurse? How does it fit as an educator? It fits for everybody because it's a process by which we make decisions, whether it's administrative decisions, clinical decisions, whatever. But with the ability to know what we know because of the availability of the literature, we are responsible to know what we should know, rather than what we kind of know, what we always know. And if we don't really ask any questions, maybe nobody will check and see if we're current or whatever. So we're going to talk about EVP as it relates to all the work that you currently do, because the future depends on what we do right now, right? And so let's start with the state of healthcare. So, how are we doing in healthcare in the U.S.? How are we doing? Things are looking great, aren't they? If we reported every day how many people we killed in healthcare, the country would be in an uproar. Because when a plane crashes, that gets reported because they roll up all that into one plane. Whereas if we had to report all the people we killed at each individual hospital every day, and then that got to be a summary statistic every day, people would be going nuts. But it doesn't happen. So we have about 200,000 unintended patient deaths per year caused in hospitals. We have 15 million patient injuries per year. If you or a loved one were admitted to the hospital today, you'd have a 1 in 10 chance of being killed or permanently disabled through our healthcare system and our care. Here's a good one. Patients receive about 55% of the care that they should. So what do you think the other 45 is? No, really?
I know.
What is all that other stuff we're doing if it's not evidence-based and stuff we should be doing? So what is all that other stuff? So it's repeating tests because that x-ray or that CT scan was done at that other hospital. And God forbid, the neurosurgeon would use that. You know what I mean? So I have to repeat that test and then repeat another test. We have to double back. We have to do things 3 times. We have to ask the same patient the same question 6 times so we look like we don't talk to each other. So we do a lot of other stuff, and a lot of the other stuff, why are we doing all this other stuff? We are covering our butts. Very litigious, want to make sure we do everything in case something bad happens, then we can go back and say, well, we did look at that, even though we didn't need it. So it's complicated how to fix all this, but anyway, here's where we're at. And we could reduce spending by about 30% if patients got just what they needed rather than all this other stuff. Okay? So the interesting thing about errors is only 5% of them are caused by true incompetence. 95% of them are caused by exactly what we just talked about, like overly complicated, doubling back, duplicative, complex, non-communicative systems, right? That we have created because Every day the message is we got to do more with less. We're eliminating 2 people, but now we add these other 6 things, right? More with less, more with less, more with less. And what we end up doing is getting more and more dangerous, right? So 95% involve competent people trying to achieve the right outcome in bad systems. Hello. And non-uniformity. And this is a huge problem in maternal child health. Non-conformity, like everybody does it different. Dr. Jones' Pitocin protocol, then Dr. Smith's Pitocin protocol. Pitocin, by the way, being one of the top 5 most dangerous drugs, which we run like water in OB. Like water. And on Tuesday, when Dr. Jones is there, we run it one way, and then Thursday, when Dr. Smith is there, we run it a different way. And at night, when he really doesn't want to come in or stay very long, we run it completely differently. So there's all this inconsistency. So this is what the poor quality cost us. In 2008, it was about $700+ billion. And so wasteful healthcare spending is about $1.2 trillion. So we're looking really great. This is just sort of stuff we know, all right? So healthcare is a mess. But what's interesting in healthcare, with all the bad stuff about healthcare, how are nurses doing in the public perception?
I think they're doing well.
We're still the most trusted people on the planet. Number 1. So no matter how many people get killed in the hospital, apparently it's not our fault. So that's great. But it's really, kind of, it's not true. But that's a good thing. We still have the public's trust. So there's even more, I think, that raises the bar for nursing. Because when I tell people what I do, and I travel all around the globe and the country, and I teach clinicians how to be evidence-based and current in their practice so they can deliver best care, because people really don't know how to do that, people say to me, really? I thought they assume we're already doing the best thing. And the fact that I go around teaching people how to give best practice, give best care, and that's my whole job, people are like, oh, that's kind of scary. I'm like, it's very scary. So I'm busy, running around as much as I can. But the assumption is, by the public, who we have an unwritten contract with as nursing experts, they think we're already doing this. So it's a good secret for now. So here's the other thing we know. If the level of your current knowledge of best practice, when you do nothing over time, that's the slope. Like, you cannot stay current without doing something. So if you stopped reading right here or stopped looking at anything in the literature, this is where your knowledge goes. It is what it is. We know this. So here's our most famous button. I know you don't need one, but I'm sure you can think of somebody who this would be a lovely gift for, right? It comes right, the minute you see this button, a face appears in front of your eyes, right? Usually people are like, I need 2 of them because I can't give it to just one, I have to give it to 2 people. So, and you'll all get this lovely gift at the end of the day. So here's what all the benchmarks, all the external people who say, what do we know about healthcare? What do we have to do to fix it? What's our goal? Everybody's talking about evidence-based practice, right? I mean, it's like you can't watch TV without evidence. Like, evidence is the new, Kleenex. It's like it's the new word, right? So what the IOM said is that by 2020, 90% of healthcare decisions will be evidence-based. That's our goal. And it's 2014, so we're not going to get there. So where do you think we're at? What percentage of healthcare decisions do you think we're at right now relative to, what percentage are evidence-based? Of all the clinical decisions we make, what percentage?
50. 50?
50? 20. 20? 20?
40.
How many?
40.
40?
20.
20?
35.
35. 35 is about right.
Wow.
And that's better. So in the last 2 years, we've made about a 5%, it's better. But it's not on a trajectory to get us to 90. But, and I'm an optimist. I'm like Mitzi Gaynor in South Pacific. I'm always thinking positive, but we're not going to get there. But we're going to try. So here's the literature on reducing errors. Use evidence-based interventions. Okay. Here's the literature on high reliability organizations, which means high risk organizations. Flying, healthcare, high reliability, where you don't make any mistakes. cultivate a culture of evidence-based practice. Okay? Patient safety. This is a systematic review of the literature that was done in 2010 on what does it take to make a safe patient environment. Evidence-based practice, right? Seeing a trend here? So with all the things you have to do, if you're going to pull one thread and get good at one thing that would help you get good at a lot of things, make it be EVP, right? Because it's also the goal of a magnet. Like if you're going for magnet, or you want to keep magnet, you need to know what this is. And there's a lot of places that say they're doing EVP, but they're not quite there. So here you can see. So you like pull out one thread, and it's going to get you good stuff. And Joint Commission too. Well, you're in this. So they're all about the evidence now too. So you can't get away from it. So you might as well learn how to get good at it, right? So here's the definition. It requires three things. So it's not evidence-only practice, it's evidence-based practice. And it's a problem-solving approach, whether it's, and we say to clinical practice, but as the ex-administrator, I say to decision-making. Leadership decision-making, clinical decision-making, whatever. And we integrate the conscientious use of the best evidence combined with expertise on the clinician side over years and years of doing things, as well as patient preferences and values. So, we've always been pretty good at expertise and knowing our patients. I think nursing has always been good at that, right? We say, we know who the patients are, we spend the most time with them, we understand their family, doctor kind of loops in and spends 5 minutes, but we really have that sort of holistic global view. The piece that nursing has not been very good at is the third leg of the stool, which is evidence. And so that's the skill set we have to get better at. Okay? So, this is a picture and the caption from a 1932 obstetrical textbook. I have it with me. So, here it is. Beautiful. So, my point is, we've been doing evidence-based practice forever, right? This is like best practice. This is cutting edge. It's in the textbook. Why do you think it's cutting edge in 1932? What do you think is innovative about that picture? Gloves. We didn't have rubber before then, right? How about the white coat? Clean, pristine white coat, right? And hold the baby upside down. Probably, was a new idea. Because people were probably thinking, oh my God, I am by his feet. But, maybe gravity will help that meconium just sort of work its way out, right? But the point is, we've been doing, we always learn from yesterday what we should, do tomorrow. And then we talk about it, and then we add something new and add something new. The difference is now we have different ways of getting at that literature much more quickly. We don't have to wait for the textbook to come out. By the time it comes out, it's already too old. We have the electronic databases with tons of literature in it, right? The trick is getting good at finding what you need, finding the needle in the haystack. And that's the EVP skills that you need to learn. So here's the steps. Okay, so way in the beginning of all EVP time, it started at step 1 and went to step 5. And Byrne and Allen, in the second edition of their book, they added step 0 because they didn't want to change all the numbers, so they added step 0 and added step 6. The reason we added step 0 was because when we went out and worked in hospitals and other clinical places, we would say to people, okay, I'm going to change practice. What are your questions? What's the stuff that's driving you crazy? That you're like, holy crap, could this possibly be the right way to do this? We've been using these same whatevers, or we've been running this the same way, or we've been doing this procedure the same way for 20 years. What are your questions? And people were like, we're good. No, seriously, like what's driving you crazy? What's your inquiry? What's the thing that you really want to get on fire about? And they'd be like, I think we're pretty good. No questions. And you know why? We've beat the questions out of nurses. Because we gave them a checklist, right? And we said, please stop thinking. This is my opinion. Please stop thinking, we've thought of everything for you. Because we go in this special office over here, we sit all day, and we come up with these checklists, and then we bring them to you and we say, just fill in the boxes. Just ask the questions, fill in the boxes, do your documentation, don't kill anybody and go home. Do not ask any questions, because when you start asking questions, it starts to really get annoying. You know what I mean? We just finished the checklist. Checklist, electronic medical records, all this new stuff, and do more with less, less people, higher workload, more acuity. Like, who has time to think? Because what we value in nursing is busyness. We don't care what you're doing, nurses, as long as you're all running around like chickens with your heads cut off, and you're busy, everybody's happy. Administrators are happy, doctors are happy, your nursing colleagues are happy, because if you sit down, who's the worst if you sit down? Your colleagues. Nurses are the worst. They're like, really, seriously? You got nothing to do? You can take one of my patients. They're mad at you because you sat down, or pee. You get a choice. You can either sit down and just take a breath, or you could pee, but you can't do both, right? So anyway, so what we said was, unless we reinvent inquiry, unless we create a culture where asking questions is required, permitted, rewarded, applauded, praised, we're never going to have any questions. And if we don't get any questions, it's all over, right? So we have to cultivate this spirit of inquiry and help people understand that we want to make sure you're the people who know what crazy stuff we're doing at the bedside, right? You're the only ones who know what craziness is going on out there. And we also have to have a culture that supports that from administration, that you're not just that one person on OB that's always got questions and is really annoying everybody. And so everybody's, annoyed. So it has to be a spirit of inquiry. So we added that one, that it's asking the question, searching, blah, blah, blah. We're going to talk more about it. But the other one we added was disseminating, right? Telling somebody about what we discovered by doing evidence-based practice, by taking the literature, putting it into practice, and seeing how it worked in the real world. Tell people what happened. Tell the people down the hall what happened, right? Bern always tells a story where she was doing a consultation and she went to this one med surgeon and they were like, oh, show us show their project about how they got falls from some crazy number all the way to 0, and they were so proud, and they were showing her storyboard, and yay! And she went down the hall and she went to the next room and she said, tell me about what you're doing. And they said, well, we're really frustrated because we have some stuff we just can't get fixed. She said, well, what's your biggest problem? Falls. She said, will you people please go down the hall and talk to your friends and say, what did you do about falls in the same hospital? Same patients. So dissemination is really, really important. So this is the same steps, but just in a different picture because there's something that's easier to see on this. So we start with our inquiry and we create a searchable question with PICO. Then we get into the literature, right? We search effectively. We find our literature and we appraise it, right? These are the steps, right? But what can happen here can go one of two ways. If you find enough evidence to support a practice change, and you're confident that you've looked at the body of evidence, and what we're doing is not the best, and we want to make a change, then you do that, right? But if in this step there's not enough evidence, like it's not compelling enough, it's not enough out there, and your question really isn't answered, you can't say, never mind, I don't want to have that question anymore. The answer is tag your it, because now you have to find a PhD buddy and do a research project so you can create some evidence, or you need to look at your own internal QI data and do something. But the answer is once you've looked at the literature, you can't just stick with the way we've always done it and not take some action whatsoever. Okay? So the reason we put this in this different picture is because sometimes there's a little side step that has to happen there. So this is a piece that people really get stuck on. Where does research and EVP and QI fit together? Are they the same thing? People keep mixing all the terms up. If I hear evidence-based research one more time, I'm going to have to hit somebody. If you hear that, there is no such thing. Evidence-based practice is practice based on external and internal research. But once you're doing evidence-based practice, you're not doing research anymore. You're doing evidence-based practice. Research is done. Now, you could do an evidence-based practice inquiry, find out there is not enough evidence, and then you would go back and do research, right? But we're going to talk about that. So here's the three different things. Simple as this. Research is a look to the outside. It says, what's the best thing to do? We're looking to the evidence outside of our own world and saying, what is the best way to change IV sites? How many, every 3 days, every 2 days, whenever they fall out. What is the best evidence on IV, changing IVs? EVP is looking internally and saying, are we doing that? What are we doing? It's reflective. It's an internal reflection. But the only way you can look internally and see if we're doing that is if you looked out there, see what should be doing. And then QI is, once we've made the practice change, to correct our practice and be best, how do we sustain it over time, and how do we quickly see if we're dipping off? But you shouldn't have a QI agenda and an EBP project agenda, and they should be different things. QI is sort of the way that evidence-based practice is maintained over time, right? So that's how they articulate with one another. So this is just a handout I have that kind of gets into how they're different. So okay, so people always say to me, it takes too much time. We don't have time to do evidence-based practice and look all this stuff up and go through we just have to make a decision. And I've spent enough years as a nurse administrator in director meetings where like some whatever hit the fan, and then everybody's got to get in the room, and we're fixing this before we leave today, right? Nobody's going home until we have a plan for tonight, right? So you get 14 directors in a room, because we just got our HCAPs back, and the noise at night is ridiculous. Like, well, I don't know, they must be having parties on every nursing floor all night long, because all the patients are saying the noise is ridiculous. And so we've been working on this, all the directors in a room, right? And we're getting a plan for tonight. So we get in the room, and all the directors, we're like, well, let's see, we tried these two things. Any other ideas? So you say, last place I worked, we tried these, we bought these, like, have you seen these things? They're like lights, red, green, yellow lights, decimeter lights. And so when the noise gets too light, the red light goes on, and that means everybody has to be quiet. So we use those at my hospital, we could try that. All right, that sounds like a good idea. So we decided to spend, $40,000 on lights. And we'll roll it out next week. And it'll be, rolled out on Monday. So where are the educators? Educators, where are they? Oh, back there. So we need a plan for the rollout on Monday for how we're going to educate everybody on the lights. And then we'll roll it out, and we'll be good to go by Tuesday, right? Okay, so So I basically call this the throw spaghetti at the wall and see what sticks, right? Okay, so you buy the lights, we do the rollout, the nurses are like, what's the plan for today? And so we roll out the lights. And then like a month later, we get our HCAPs back. Guess what? How's noise at night going for you? Still sucks, right? Okay, all the directors back in a room. We yell louder, and we say, okay, so that great idea didn't work, you being competent directors. Now what are we going to do? Because nobody's leaving here until we have a plan, right? So somebody else throws out an idea. Well, in my hospital, we did administrative rounds. Everybody's like, great. So now all the administrators are annoyed because now they have to work nights. But we're going to do that. Okay, so the educators, we're going to need a plan for that because we need to roll that out on Monday, right? And so then the administrators start doing rounds. And so they do, cleverly, they do the second floor, then the third floor, then the fourth floor. So when they're done on the second floor, they call the third floor and say, they're coming. Shh, they're coming. Because the nurses have this figured out, right? And so basically, then we try that. And the staff is like, you people, seriously? That's not going to work. But anyway, we tried. Then the next month comes back and we get the HCAPs. Guess what? That didn't work either. And who's fatigued by this? Who's fatigued by all these changes that don't work? And a new idea every month. The staff, or they're change fatigued, and they think it's craziness, right? Months have gone by. We're 3, 4, 5 months into noise at night problem. 5 months in, and we haven't fixed it. And people tell me, this takes too much time? Looking at the literature when we have a problem, taking it 2 weeks to look at the literature and find out what works out there, picking that and doing that, will you have a chance of success? That takes more time. That does not take more time. It's just where you want to spend your time, okay? So this is the route to madness, which we, this is the explanation of that. Whereas this whole, usually if you get it right, you change it once. Now with all the things we have to address in hospitals, and all kinds of stuff, that's just like 8 changes just for noise at night. That has nothing to do with it's too cold, the food stinks, nobody answered the call bell, what?
Cleanliness.
It's not clean, nobody talks to each other, they asked me the same question 6 times, the doctor was mean, I didn't understand it. Like 11 rounds of change for every one of those things. People are like, you know what, I'm done. Just wait, because they'll just change their mind. They're not doing it. We've lost people by doing it this way. And so my point is, anything we would do that's informed by good information would be better than the way we do it right now. And I can speak from experience because I sat through a lot of those meetings. So why should we bother? So here's the slide that should be the end of the show, which is when patients get evidence-based care, they have somewhere between 28 and 35% improvement in their outcomes. Like, I should leave now because like, what else is there to say? What else do you need to hear? Now, if you're a family member or that patient, would you not want somewhere between 28 and 35% improvement in their outcomes? You would, and you knew that was possible? You'd be outraged if that wasn't what we were all doing all day, every day, or aspiring to, right? So that's one reason. Here's the other reason. By the way, it's your job, right? So when you say, I'm a nurse, that means people think you're good at that. People think you're an expert at that, right? I'm not saying I'm a history teacher, because I don't know anything about the Civil War. Well, I know a little bit, but like I'm not an expert in that. But if I say I'm a nurse, you had better be good at it. And doing the same thing you've been doing for the last 26 years is a breach of your contract with the public. So it's your job. It's also in the Nursing Code of Ethics. It says it right there, and we wrote that. We say we're the boss of this. We know best. We'll handle this. We know nursing. So it's better for patients, and it's your job. So now we just have to figure out how to do it. So these are what the responsibilities of any expert are. You know, you have a higher obligation. It's not entirely cognitive; it's relationship, and you're required to have the best evidence to support your decisions. That's what an expert is responsible. Whether you're an expert bridge builder or architect or farmer, whatever, you're the best. So here's some of the language in the Code of Ethics. I'll give this to you, but you know, here's there's a lot of good language in here. You know, we're responsible for your safety and the integrity of the care you receive, and we advocate for you, and we participate in establishing the best environments for you, and we participate in the advancement of the profession, et cetera, et cetera. So the definition of EVP, it's a professional obligation, right? And if you don't do it, it's unethical, really. So we know it's best for patients. We know it's our job. We know it's possible to do. And so in spite of that, here's what we do. We conduct practice that's based on tradition and anecdote. And we know it's not best. There's something, and this is moral distress territory now, right? You're in that situation where you actually know what the right thing to do is, and it's not happening, and you can't get the doctor to step out and have a little conversation. So you're going down this path of what you know is not good, and this is what tears nurses up. Because we haven't found a voice. This is a great way to get the voice. We deliver provider-centered care. We'll talk about that. And we tolerate the gap. The research is out there, but it's just not in practice. We tolerate that. And we conduct inquiry without looking at the so what factors. That's some of what we talk about. Like we do a lot of research in nursing that's about like warm and fuzzy stuff that nobody really cares about. Whereas if you really want to get evidence into practice, we've got to be looking at stuff that articulates with what's important in healthcare. Length of stay, these are the things that keep the hospital open, And we let the barriers to EVP persist. So let's talk about some of our favorite tradition-based care. Give me some examples. Stuff we just do because we've always done it that way. We have no idea why.
Turn every 2 hours.
Turn every 2 hours. Sounds like fun. It's a good example. What else? Vital signs every 2 or 4 or whatever spaghetti you want to throw at the wall on that one. Right? How about vital signs Q4 hours at night, so we wake people up to see if they're having blood pressure. Right? So what we know about that one, not only is there no evidence to support vital signs every 4 hours for no reason, but what do we know about waking people up when they're sleeping? Sick people need to sleep. Sleep is very, very effective for healing. So not only do we do something that we have no reason for doing, but we're doing something harmful in order to do the thing that has no evidence to support it. So it's like a double one, right? Let's see, what else? Here's some of my favorites. Daily changing of IV dressings. Ridiculous. Some places now are doing it every 2 days, some places are doing it every 3 days. Pediatrics, that sucker's falling out before we're taking that out. Like, The only reason we take IVs out of a 3-year-old is because they're not running anymore, and we know it, right? Because pediatric nurses are not sticking any 3-year-old any extra time. Because it's a life-threatening experience, right? Foley catheters for everybody. Now this is changing, but I mean seriously, a couple years ago, even in OB, you got a Foley whether you want one or not, just for the fun of it. Because you know that way you don't have to get up. You know, just pee in the bag. Here's another one. Strict NPO after midnight. Where's my OR lady? No evidence. You know what they call it in the UK? Starvation. Like they don't starve patients before the OR. Now they don't give them a big fat, cheeseburger. But strict NPO, like nothing to eat or drink, is completely ridiculous. And there's no evidence to support it. Okay, and albuterol delivered with nebulizers. We have known since 1992 that MDIs and spacers are cost-effective, more effective for patients, and less scary for kids, and they work faster, and less kids get admitted. But I will tell you, 80% of the ERs across this country, if you walked into them and there was a kid with asthma, how are they getting their albuterol? Screaming, crying, bright red face, parents are freaked out. No need. So this is some of our traditional stuff that we just do. See, I need to fix this slide because this is about 35 now. Okay, so then the other thing that we're great at is provider-centric care. It's all about us, and the patient should just have to deal with it. Right? So what are some examples of that? What's all about us in our care?
When we do it.
Yeah, when we do stuff. The lab's coming at 4:30 a.m. to just like wake you from sleep and stick a needle in your arm. I know some hospitals in the local area where apparently radiology comes at 2 a.m. They do all their radiology, like all the bedside x-rays at 2 a.m. and then the lab comes at 5. So yeah, how about restricted ICU visiting hours? Like people can visit between 2 and 4 on Thursdays. If you can show proof of relationship, right? It's crazy. It's like, these are our people. Like the family will wait out in like some crazy waiting room and so here's some of these good ones. Physicians rounding at 11 p.m. Because then there's no people there to annoy them. No families with all those stupid annoying questions, right? Or the pediatricians rounding in the nursery and you have to bring all the babies back from their mothers, because they wouldn't want to go in the rooms because the mom's going to ask them a question. Same mom who's going to ask him the question 2 or 3 days later in their office. Okay? Foleys, we did that. So the Foleys are both non-evidence-based and all about us. Because half the Foleys are going in just so that we don't have to get you up at night, right? Infants return to the central nursery. Right? We want those moms and babies to be together. Now, there is a ton of literature that moms and babies should be together, right? They like each other. Now in New Jersey, apparently not, because when I tried to make these changes in the nurseries that I worked in New Jersey, the nurses were like, look, these moms are exhausted. They do not want these babies. I'm like, really? Because the literature pretty clear on this. They're like, well, they're not here. Well, New Jersey is a special place, as we all know. So I said, okay, so maybe that's true. Let's pretend no mother in New Jersey wants her baby at night. What do you think the babies want? Mom. They do not want to be in the nursery with 5 other babies and 1 LPN. They don't want that. Lights are on, it's noisy, they're wet, they're cranky, they never heard that voice before. It's miserable. They don't want to be there. So if all the moms don't want their babies and all the babies want their moms, it's a tie. And you're the tiebreaker. What do you think? Okay, so we know, and here's my favorite. This is with the nurse administrators. Nurses working 3 days a week. Who's that about? Is that about patients? Because what do we know about 12-hour shifts? They're deadly. Deadly for patients. We have more med errors and really, really horrendous errors after 8 hours of work. And many people who work 312s for you, They're working 3/12 for somebody else too. So they're not just working 3/12, they're working 6. And it's bad. So I hear you, like, here's the thing. So, that's a tough one. The nurses want to work 3 days a week. And so you have to find your voice for this, but here's the Jersey voice. I hear you, but it's not about you. Like, yeah, I would be 5'8", but like, that's not happening either. So, what's that shift that like they just don't want to? Well, that's not what I'm asking. We have to kind of reframe with what we know. How do we reframe that conversation, which is, 12-hour shifts are dangerous for our patients. So we're going to have to move to 8-hour shifts because the literature really is clear that that's when patients get the best, safest care. So everybody's going to have to like figure that out. We might get in 6 months from now, kids can change their lives, but like, who else works 3 days a week? It's so much better for patients, and that's what our job is. So anyway, I just throw that one out because EVP is not just for staff nurses; it's for nurse administrators too. Okay, so I don't want to spend a lot of time on this stuff because. So let's talk about why this is difficult in nursing. Like, why is getting evidence-based practice into our social world so difficult? And it's because we're very social, right? So when you get out of your car and you're walking into work and you see who else is showing up, you know exactly what kind of the next 12 hours are going to look like, right? Because you're like, oh my God, is Becky going to be? Oh, there she is. She's always in charge. And when she's in charge, it sucks. It's like, ah. But on the next night, you see Kathy. You're like, oh, Kathy will be in charge. It's going to be great. Everybody will be fair and, balance and all that kind of stuff. So it's a very social thing. Every night the team is different. Very difficult to manage a different team every night, right? Like if I'm the manager of the New York Yankees, I know who's showing up every day and I know who's playing first. I know, I know what's happening. But if those same people, a different group of people showed up every night, it's much more difficult, right? So it's tough. The other thing is this busyness thing I talked about. So everybody loves nurses to be busy. Here's a study from 2013. Check this out. Nurses perform a high number and large variety of activities in short periods of time. The average number of nurses, this is an ICU, adult, cardiac, and pediatric ICU. Average number of nurse activities per hour was 125. Per hour times 12 without peeing or eating, usually, right? So like your glycemic index is not fit for thinking of any kind, and you're doing 125 things per hour. Nurses in the ICU switch between activities every 29 seconds, on average. Think about that. Every time you switch activities, there's an opportunity for a disconnect, right? So this is their quote. Nurses' work is unremittingly busy and frequently changing. Who's the most interrupted people in healthcare? Nurses, right? No matter what you're doing, it's not as important as what the doctor wants to tell you, or the housekeeper wants to tell you, or the family member wants to tell you, or whatever. There's no boundaries to how much we can be interrupted. It's just socially accepted that whatever you're doing, you're interruptible. Who interrupts nurses more than anybody? Other nurses. And nurses are interrupted on a large number, oftentimes during med administration. And when they're interrupted during med administration, most likely to be interrupted during IV pushes because they're standing still. Like you're a captive audience during like our most high risk stuff. But if you're standing still, somebody's going to be talking to you, right? So now all these places have had, make you wear an orange vest or a hat or some silliness like that. Like any nurse with a red hat means she's giving meds. It's like, are you serious? Can't the nurse say, could you just hold on a minute? I'm giving meds. Like it's like the Little Mermaid. Like we sold our voice to get the, don't get me started on that. But like we have voices,
That's the first I've heard of it.
The evidence says that if you interrupt me, I may give your mother the wrong med. So please don't interrupt me. As soon as I'm done, we'll talk. It's okay. Like if you say, I might kill your mother, depending on who the mother is, or whoever, I'll like gauge that. But if you frame it that way, that what I'm doing is really important, I need to concentrate. It's okay to say these things, right? Okay, so this is kind of what nurses do. 76% are patient care activities, 20% is documentation. That's a low number. Because on med-surg, it's like 60% of a nurse's day now is documentation. Okay, so back in 2005, this was the first study about nurses and EVP. Are we ready? What do nurses think about EVP? The answer was, I'm pretty sure it's not for us. I think it's a doctor thing, right? Like, we don't really need to look anything up. I'll just ask Mary. Because I worked with her for 22 years and we agree on everything, right? So 67% sought information only from colleagues. Almost 70% of nurses in 2005 didn't ever look at anything other than their friends for information. 39% felt they rarely ever needed information. 40%, I don't need to know anything more than what I already know because I know everything. 82% had never used the library or a librarian, and sometimes that's because we didn't have keys because it was the medical library. Give you that. And, so we were in a pretty bad place. So we did a study at Ohio State with the ANA back in 2010, published in 2011, on like, has anything changed? Like, where are we at? Where are nurses at with EVP? And here it is, and here's what we found. There's over 1,000 nurses, blah, 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 blah. Here's what we found. EVP is consistently implemented in my system, 53%. My colleagues consistently implement it, 35%. So there's some, people are doing it, 35, but it's happening, 55. So some magic gnomes are doing the other part, I don't know. EVP mentors, which we know are critical, people who really know how to do this, that can help other people, only in 33%. And 76% said, I need to know more about it. I really want to know more. I just don't know how to do it. I know it's important. So things are really different. 5 years later, things have really changed. Nurses get it, that it's important. They just don't know how to do it, and the organizational culture doesn't support it. So we have new barriers. Magnet, I'm not going to spend a lot of time. Here's the interesting, the more years in practice, the less nurses were interested and felt it was important to learn about EVP. Shocking news, right? I mean, I've actually had people say to me, look, I'm retiring in 6 months, I'm not learning anything. Really? Really? More highly educated nurses were more clear because they're learning it in school, which is good. So here's what we asked, one thing that prevents you from implementing EVP. What's the one thing? So this is the age-old, time. That was the number one. It's always number one. It takes too much time. I don't know how to do it. I don't have any help. We're too busy, right? Organizational culture. This is the way we've always done it here. Shush. So these we knew about. Lack of knowledge is old. Lack of access. Here's the new one. Manager and leader resistance. That was big news. That is a whole new finding. And good for nurses in this study who had the courage to say, yeah, they tell us we're really into it. They sent me to a class. We started an EVP and Research Council, and I haven't been able to go to the meeting once this year because we're too busy. Or somebody called out. Or the labor bus just pulled out. Well, there's always a reason why you can't actually go do it. So we have not done a good enough job of teaching leaders and managers what this is and why it's important. We spend a lot of time at the staff level and sort of in the academic side, but we haven't really tapped into these folks, so there's a lot of push here right now. We just did a big study with CNOs, and we're presenting it as a pre-conference at the AONE conference on what did we find about characteristics of the CNOs and leadership related to their EVP beliefs and their EVP and their core measures, their NDNQI and their HCAPS, and are there any correlations? So that's what, we were going to talk about what does a high-performing nurse executive and place look like, but we can't find that picture in this. And there's almost 400 CNOs answered this survey, huge survey. So the fact that there's not really any correlations, it becomes what we need to talk about. So, be interesting. And then, again, good for the nurses, workload. And I was the person who got to go through all this qualitative data. They didn't just say workload. They said backbreaking, unsafe, scary, ridiculous, lots of big words. They're really being crushed by the workload. And their colleagues are resistant also. So things are changing, you know what I mean? We have new barriers, we still have some old ones, but we have some new ones. So here's the big one. It's kind of a scary slide. But basically, this is what people say, you want me to do this on top of everything else? And I say, no, I want you to do it as the foundation of everything you do. And when we can teach it in a way and incorporate it in a way that we wouldn't do anything without thinking about it this way, then we're there. It's the DNA, it's the foundation. But when they think it's something else they have to do, they shut down because they can't do anymore. So here's what I say about more with less. The answer is we're not doing more with less. We can't. And what we've learned is when we keep adding and adding and adding, it hasn't made things safer. It's made things more dangerous. So I would say if you want us to do something new, we have to stop doing something stupid. Right? That's the deal. So we have to figure out what's the stupidest thing we're doing, and we'll stop doing that. Then we can do this other new thing, as long as it's evidence-based. But we cannot do more with less. Like, it's ridiculous. And it's not fixing things. So time is a problem. So I'm making it being the foundation. So this is complicated. It's not that easy. But here's the thing. Dear optimist, pessimist, and realist, while you guys were busy arguing about the glass of water, I drank it. Like the opportunist, you know? Well, is it too late? No, it's not. It's like, let's just do it, all right? Now, I am that kind of person, but, I mean, come on already. We have 10, 15 years of data here that says we're killing people. We're acting crazy, and we know how to fix it. So what do we have to do? Clinicians. What do the clinicians need to do? We need to go, get to every clinician and say, this is important. What do you know about it? How do you feel about it? Do you think it's important? You know, it's ethical. It's your job. What do I need to do for you? Help you get there. But your response, it's intrinsic. Everybody's got to get on board, because if you change a process and less than 95% of the people do the process the new way, it won't happen. Because the 5 who aren't doing it, kill it. Right? And you know who they are. It's Mary on Nice. She'll kill any project. She loves killing projects. What are you going to do about it? You know she's the killer. Right? So the individual matters. You can't just kind of go out and say, we're doing this. You have to really look at where are people at in this organization. If we're starting here, people are happy and they seem sort of, able to take on another piece of something, that's different than this person. If everybody in the organization looks like that, you have a different strategy is needed to change how practice is going to happen. We have to connect EBP to what nurses care about. What do nurses care about? What's the one thing we can agree on? They want to take good care of their patients. Why else would they come back? Right? It's a really hard job. It's it'll wear you out, but they really are motivated and committed to taking care of patients. So if we know that evidence-based practice is better for patients, that's the way to go. Because what we know is if nurses believe EBP is important, they really believe it's important, and they believe they can do it, they'll do it. If it's connected and they believe it's important and we give them the skill set, they implement it more. There's not a study out there that doesn't show that. But we got to do both those things. We have to make it connected, and we have to teach them how to do it. Leaders. Leaders have to be evidence-based. They need to know what it is. They have to walk the talk. They have to be evidence-based in their decisions. So when we roll out, the new lights, we can say, this is why we bought the lights, because the literature says, the lights work. Here's the synthesis table. Lights are great. That's why we bought them. They should work here too. Right? Not just we had a meeting and we said, let's try lights. Because, they need to model EBP, and this is my biggie for them. They need to publicly navigate EBP barriers. They need to be out there when you're trying to roll out EBP on a unit and somebody's a doctor, whatever, showed up and seriously, when I did that family-centered care, public care thing, this was my favorite story. So we closed the nursery, right? No nursery at night, because we didn't need it anymore, because babies were with their moms. After months of preparation, because baby nurses don't take care of mothers, and mother nurses don't care of babies. So it took a year for everybody to get cross-trained. I said to people, what happens when there's a breastfeeding problem? Is that does the breast nurse deal with that, or the baby's mouth nurse deal with that? So, we would roll it out for a couple of weeks, and, still wasn't that smooth. And one of the chief of OB, one of his, and here's how the nurse presents, the baby's going to be with you tonight. You're administration said you had to have your baby tonight, so, good luck with that. Basically, was the message. The mom was crying, and she was upset, so she complained to her doctor the next day. So he comes out to the desk, and he writes an order. Discontinue family-centered care. The nurses were like, oh my God. So they call me, and they tell me this, and I'm like, So I go up there, and I'm like, Frank, because he calls me Lynn, so I call him Frank. I'm like, Frank, what? He's like, he's just completely unraveled by this whole thing, and Not one person on the floor, after months of preparation, had the courage or the voice to explain to him, here's why we're doing this. Here's all, it's the right thing to do. Now, how are we going to go help this mom understand that? Because clearly we haven't communicated appropriately. I mean, that's what I needed to do. As the administrator, as the EVP champ, all those things. Basically go up there and say, we're doing the right thing. Perhaps we didn't execute it properly, but here's why we're doing this. And we need to work together. And we're doing it, Frank. Like, we're not discontinuing. Now, unless you want to work tonight, because we don't have a nurse. So you're on 7P to 7A. So administrators have to create these environments. And some of these things are easy. You can do some education, you can do some skill building, we can try to work through our operational budgets, we can create positions, we can add EVP to certain job descriptions. And then there's some other things that are more difficult. You got to deal with workload. Like, this is what administrators have on their plate. Like, what are we going to do to get people a little bit of time and let them get to the meeting and let them do these projects and let them practice these skills? So there's a lot of work to be done with administration, but that's okay. So it has to be possible in the real world, and that means everybody. Everybody's in. Administration from the top, throughout, right to the bedside, everybody's in. It's not negotiable. We're doing this. How we get there is unique to us. And this is what my old boss used to say, what we permit, we promote. So is this what we really want nursing to look like? Because this is what it looks like. When you go look up nursing, images, this is what we look at. Look at it, on the phone, buried in paper, running, yelling at each other, and documenting. Rarely do you find a picture of a nurse, in the patient, because we don't do it anymore. It's hard to get a picture of that. Nurses aren't touching people anymore, right? So what do we want, so what do we want it to look like? That's what we need to be moving towards. What are the things that we bring that are evidence-based that they can't live without? Because if we don't make a case for what we do that the hospitals can't live without, guess what? We go away. We get a few more techs, they'll get a few more respiratory therapists, they'll get a couple more case managers. We gave away all the good stuff, so let's take it back. All right, so as long as we keep the patients front and center, this is what we're always focused on. You'll never go wrong, right? So how do we teach this? So we can just say, okay, we're going to build a ship. You get the planks, you get the nails, and then we'll build a ship. But if you really want to build a ship, you got to teach people to love being on the sea. You got to teach them that we wouldn't do it any other way. That's why we built the ship with love. You know what I mean? It's a different, you can't just do this piecemeal. It's got to really be, sort of a package. This is what we're going to do. So here's the critical things for an EVP culture. Philosophy, mission, strategic plan, it's got to be in there. When you walk in the hospital, this language should be in your mission. Evidence-based, best practice, current practice, whatever you want, but it's got to be visible. You have to have the spirit of inquiry. It has to be built in. Like in My Perfect Hospital, when we do your annual review, you need to tell me what were your questions this year. Because you didn't have a question all year, you're disengaged. There's something wrong like this. You're not really paying attention. Cadre of EVP mentors. You have to have this skill set. And not everybody is going to be an EVP guru. But you've got to have, strategically within the organization, enough EVP knowledge and EVP change agents to make it thick. You can't just have one person doing this. You have to have administrative role modeling and administrative support, infrastructure. This is what we've done a good job of. We've bought stuff. Computers, sent people some classes, picked up, bought Mosby. We bought Mosby. We're EVP, we got Mosby. I'm like, really? And recognition, big deal. Small wins, recognizing, posters, parties, whatever. So here's just a different picture of that. But these are the things that we know are facilitators, knowledge and skills, belief that it's important, and belief that you can do it, and mentors, and administration. That's what we know you need to get this going. So, there's different things about it. We have these different tools where you can assess the order. We have tools for everything. Seriously, we need a tool to measure this, or to get good at this. I have a tool, so call me. But we have this tool where you can assess where your organization is at, like how ready are you? And so these are just some of the example questions. But what we get to is, there's three different, so there's like an organizational culture. So this would be like the Ohio State University Medical Center fruit stand. Like they do everything, right? They got every kind of fruit from all over the world. There it is. But different kinds of places that have every kind of fruit, the context of how the fruit is delivered can look different. Some places are a little more like fruit salad, you know what I mean? And some places are very rigid, very organized. So when I worked in Philadelphia, this is CHOP, Children's Hospital of Philadelphia, and this is St. Christopher's. Okay, St. Christopher's is in like the Hispanic section of the city, very like community-based, awesome hospital. Does all the same stuff, but it's like the community medical center. CHOP, the Mecca, you know? Like, they're organized. They have a policy book that could like stop traffic, okay? So you can get the same stuff done, but like what's the context in which your organization defines itself? Are you a very rigid place, or very rule-bound, or are you a place where there's some flexibility built in? These are the kind of things you need to assess, because if you're gonna change practice in this place, your plan is gonna look different than changing practice in this place. So these are the kind of things you need to think about as you're doing this. And then, so you have your culture, the context, how the culture is, you know, the stuff we do, how it's delivered, and then every day, the climate changes, right? So how does the fruit look today? So some days the fruits stay nice and organized. Other days the fruit's a little, you know, stacked up. Some days it's a little on fire, and some days it's just a freaking smoothie, all right? Just a smoothie. This is labor and delivery. We know what this looks like, right? The ER. Like some days it's just not a good day to roll out the new project. Like if you don't pay attention to this stuff, all this will fail because, well, you know, it's like we're doing that new thing on Tuesday. No matter what Tuesday looks like, it will fail. Because if Tuesday's a smoothie day, it won't work. So you have to have people that are moving EBP culturally in the organization that understand the organization. So don't make these mistakes. It's a team sport, you know what I mean? Like you can't just do this with one person. There's a lot of stuff that has to, you know, individual people have to do different things, but ultimately EBP is an organizational change, right? So here's what every nurse or every employee needs to do. They need to take a look at themselves. Where are they at? How do they feel about it? They got to learn some new stuff. They have to develop a reflective and curious practice, which is new for some people and killed off in other people. And they have to promote it in others, and they have to participate. So we, again, new publication coming out of our center. We have developed through a scientific process the Delphi study, which is a panel of experts and then other experts validating what they said in a couple of rounds. EBP competencies for practicing registered nurses and practicing advanced practice nurses. So what should a practicing nurse be able to do? Does she need to like do an EBP project all by herself, or does she need to participate? So there's 14 competencies for nurses and an additional 11 for advanced practice nurses. They're coming out this month. That will be very helpful to hospitals because they can insert them into their clinical ladders and their job. Like it's not, like at our hospital, EBP looks like this for nurses. And at our hospital, we have them do this. It's done. It's scientifically derived, ready for you to, so we're in, lots of places are piloting, getting these competencies into place, like some in their clinical ladder, some in their job descriptions, some in their policy and procedure committees. So we're trying to create, you know, other ways to make this less soft.
Where's that being published then?
Worldviews. Okay, so here's what the nurses need to do. Promote it, know the steps, and participate. Okay? So, and then when nurses get engaged in this, it's very empowering. Because we get to fix our problems. You know, we get to say what's driving us crazy and fix it. And then the nurse who had the question gets to own the fix. We get to stop doing stupid things or inconsistent things because we have, the evidence is our power. You know, because it's not just what we want to do. No, who's going to fight with us when we have this like incredible, knowledge-driven confidence to say this is the right thing to do? What do you got? I mean, that's what I say to people when they say, well, you know, I don't like that evidence. It's like, well, did I miss something? Is there an, you know, maybe I missed an article. Like, bring it, I'll add it. And maybe it'll change this picture. But from what I can tell, from all the literature we've looked at, where you should be moving in the right direction. But if I miss something, please bring it, doctor, whatever. You know, like that article from 62 that you learned at Penn by your Penn guy, and you've been doing it ever since. Bring it. And if it changes the picture of our body of evidence, we'll fix that. But chances are it won't, but very empowering. It gives nurses great voice. Okay. So be inquisitive in question practice. That's basically what you need to be able to do. Know what a PICO question is. You know, what they're used for. You know, understand the steps. PICO questions are a search strategy. They help you get from, like, nurses are very inductive. You know, we think in paragraphs because we want to know about you and your dog and your husband and your car and your house and your blah, 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 blah. Because when you get slammed with this new diagnosis, we want to see how does that diagnosis fit into your world. And that's what we do. Doctors are very deductive. They just want to get to the diagnosis and leave, right? That's fine. That's why we both need both. But when I say, what are you wondering about? They usually give me a big paragraph. But that's okay, because that's how we think. And then we have to help them get to the PICO question, which is identifying key terms so you can search to get the answer to your question. Because if you search by paragraph form, you'll never get the answer, right? So it's hard in nursing because nurses they tell you a big story. And then I say, well, what's the question? And then they tell you a little bit shorter story. And then I say, well, what's the question? And they tell you a little short. You know, we kind of chunk it down till we get there. Then we search. Then we appraise the literature, different than critique, not research. What's an appraisal? What do you get appraised? Diamonds, cars, houses, colleges for your kids. So I have 2 kids. One is sort of a sciencey guy, and one is an oil painter. So when we went out to look for colleges for them, did we even look at the same colleges? No. So when we have 2 different situations in nursing, are we going to always look at the same place for the answer? Sometimes we're going to go to PubMed, sometimes we're going to go to CINAHL, sometimes we're going to, and you and I could read the same article, 2 different questions, read the same article, but to answer your question, this is a great article, but to answer my question, not so great, right? But you have to get good at appraising it, and appraising it is different than critique because appraising is what worth does this article, this study, bring to answering my question? Is it well done? These are the key questions. Is it well done? What did they find? And does it apply to me and my patients, right? That's appraisal. And then we appraise each of the articles that we found that answer a question. 1, 2, 3, 4, 5. And then we take all those articles, we put them together, and we synthesize them. What is synthesis? What's different about synthesis? Bloom's taxonomy, right? It's not describe. It's not list, it's not delineate, it's synthesize. It's a much higher level. It means create something new, right? I've synthesized all these pieces to create this new thing. And what the new thing is, what am I going to do with all this information? It means we're going to change practice or we're going to do some research and add to that practice because there's not enough. But we're going to do something. That's synthesis. But EBP is not what we have always done. It's not research utilization because that's somebody went to a conference, heard a great presentation, and said, let's do that here with one article or one presentation. Not good enough. It's the body of evidence that's out there to answer your question, and you're sure you've looked at it. And then you created a picture that says, this is the compelling evidence that says, waking people up at night every 3 hours is cuckoo crazy. We're not doing it anymore. That's synthesis. So we look at the strength of the evidence, like how rigorous was the type of study, how well was it done, does it apply to our patient population, and help answer our question, and then we do something about it. These are some examples of synthesis tables. Sort of like, the whole idea of synthesis tables is to put all your articles on here and all the outcomes you're looking at, so you can step back and have a visual picture and say, wow, this is our rapid response team. So when you do a rapid response team, what happens to hospital mortality rate in all 15 articles? Codes outside the ICU in all those hospitals. Well, how do you like that data? Like, if you don't have a rapid response team, and this is the 15 articles that are dead on, that answer your question, what would you say? Should we do that? Do the outcomes always move in the right direction? Hospital mortality rate always goes down. Codes outside the ICU always go down when you have a rapid response team. Like if you don't do it, then what? The next person who craps out on the floor is going to say, well, somebody told me you did a whole study on this. Why didn't you do it? Right? So there's the return on investment, which is ROI. And then the other ROI is risk of ignoring. When you have data that's compelling, you got to do something about it. So this is what you'll learn if you come and spend a week with me. But we have to make a decision. Is your current practice best? If yes, there's the party. Like the no change today party, nothing new rolling out, pizza party. If the answer is no, then you have to say, okay, what's the plan for making a change? But either way, you should do something. And then there's just do it. So here's me, like jump off the cliff. Let's get it done, right? That's my personality. You have the data, I'm confident, like let's just get it done. So people like me need people like this. So these are, you have to have balance. Somebody who says, what about the, wait, you don't have a life preserver on. Like you can't jump off the cliff without a life preserver. I'm like, oh, right, okay. But we can't have analysis to paralysis with these people, where it's like, well, wait a minute, we're not really ready. Well, I'm not sure, like you have to find that balance. At some point you do have to jump off the cliff, but hopefully your friend helped you remember your life preserver, okay? Then we have to measure our outcomes, because the point of evidence-based practice is we're taking stuff from research where there's a lot of control, right? Randomized control trials, we control for all these confounding variables and all this other stuff. And then we take that evidence and we put it in the real world. So if in the scientific pristine world where everything else was controlled for, they got a 20% improvement in the outcome, and then we applied it in the real world and we got a 10% improvement, we're like, we didn't get the same results. Well, of course not. Because these are real people in the real world. But we got 10%. That's great. We had a major improvement. So tell everybody. Like in the real world, it looks like this. You won't get the same. Of course you won't get the same. But that's why we have to do evidence-based practice, so we can test the science. Tell other people. And these are what these EVP mentors do. We've got to have them. This is Byrne and Ellen's model. So I don't know, there's a lot of EVP models out there. There's the Iowa model, there's Oswald and Larrabee. A lot of them are like how to do an EVP project. Byrne and Ellen's model is how to change your organization. Okay, so this is an organizational model, which basically centers around developing these EVP mentors. Doing an assessment with these tools, valid and reliable tools, identifying strengths and weaknesses, creating this cadre of mentors. And when you have these mentors, beliefs change, implementation changes, and then we have lots of studies now, like 9 or 10 randomized control trials where we're starting to see these things: nursing satisfaction, cohesion, intent to leave going down, turnover going down, and improve patient outcomes, and ultimately decrease costs. And you know what's ironic? It's the only evidence-based practice model that has evidence to support it. Because they tested it before they really do too much else with it. So, all right, so we're going to kind of roll through this mentor stuff. But this is sort of what happens when you get EVP going. People are inquisitive, they're supported to explore and discover new answers and own the answers and own the fixes that really work. Not wasting so much time, and ultimately it all loops back into delivering best care. Okay, so we talked about this: recognition, engaged leadership, believing, strategic. You gotta have a plan. And you got to be persistent. You can't just tell people we're going to do EVP now. You're kind of didactic. You have to be very engaging. And so here's just a piece of advice. Don't try to boil the ocean. Like small, low-hanging fruit, easy wins, stuff that's not going to like tick off the cardiothoracic surgeons for your first project, because that's probably not politically too smart. Here it is: high impact, low effort, low cost, politically benign. Do some easy stuff first, let people get a feel for it, right? Change is a big deal. We know about this. It makes people cry, upset, Some people like change, not most, right? So we know from, the bigger the change, the more traumatic. Everybody has to change in order for the place to change. The leader has to be willing to change. This is my favorite change theory, diffusion of innovation. This came from this guy Rogers. It started in agriculture. With introducing new farm equipment to old farmers. And it's like, it runs through anything. But anyway, what we know is in any organization or group, 2.5% of people are innovators, right? They're on board. They're like, yeah, let's do it. Only 2%, right? 13% of the early adopters, they look at these guys and go, he seems to be working on okay for, our like dicey, edgy people, right? And then these people look at these people. But these early adopters are really key. These are the people you gotta, get them going. 13%. Look at this big chunk here, early majority. 34%. When you get these people, that's when you get the change, right? You're not getting it, you're really not making a true shift until you get this group. And then once you get this, these guys come on board. And see those 16 up there? They're called laggards. Guess what? They're not coming, no matter what you do. What's the 80-20 rule? Most managers spend 80% of their time on that 20%. So my recommendation, how much time should you spend on those people? 0. 0. They're not coming. So the only time you should spend with them is ignoring them, and just like making them like the outside of what's going on, because they're not coming. You have to have a plan for how you're going to help them exit. But don't spend your time trying to get them on board with the project or EBP or whatever. They're not coming. So this is a classic model that has been used a million times, and I just, it's fun to kind of know who they are because you can walk around and say, oh, yeah, almost got that early adopter group done. I know there's, so-and-so. One of my laggards. Okay, so use the resources, your team. There's lots of stuff out there. There's experts nearby, right? We have some tools. The AJN series, I don't know if you're familiar with it. It's 12 articles we wrote out at ASU. It's step-by-step an EVP project with 2 staff nurses about the rapid response team. It's a great series. It's written very, it's simple. It's not like, oh, you're simple, but it's simply walks through the process. So if you're at any stage in the EVP process, you can pull out that article that really talks about it. And it's had more hits in the AJN than in the history of the AJN ever. And it's not because, well, partly it's so fabulously written, of course, but it's because people want to know how to do this. And this series of articles is just been embraced as this will walk you through it. And so it's won a lot of awards and stuff, but it's it's free. It's AJN EVP series. Just download them. You can get some CEs for some of them. We're here, we're right down the road. If you have a project you want to do, I would love to be more involved with some of these. Like, we know how to get this done in hospitals, but we don't know how to get it done where you are. My front row person. What's your name?
Bonnie.
Bonnie, I know what you did. Like, we haven't figured out how to really get this going in like long-term care where there's no nurses. There's like an LPN and like 12 aides. How do you get this sort of thing going there? How do you do it in rehab? How do you do it in your kind of environment? Like, it's different, and I'm working with the public health nurses, I'm working with school nurses. It looks a little different in all these places. So for all of you who are, maybe, I'd love to do an ER project because they're a whole different. Lots of places are doing it, but I'd love to work with the Emergency Room Nurses Association. Like, how does this look different in the ER with ER kind of people? How does it work in, the OR? They're like a whole different breed. You know what I mean? How do you get this going in the OR with surgeons, right? So we're doing lots of cool stuff, but if anybody wants to kind of talk about any of that, that would be great. We did that. And then, this is really it. You just kind of got to be creative. The person who's going to be the champion of this cannot be like the most boring person you ever met. They can be like, they've got to be, engaged. They have to have some relationship with people. And what we found for EVP mentors, the best people are advanced practice nurses, clin specs, nurse practitioners, because the staff look to them as knowledge brokers, and they have a relationship. They don't have to create that relationship. They've already got that clinical bedside relationship. I call it evidence to gift. If I had known this through my administrative career, I had a lot less fights. But better late than never, And again, there's no fighting anymore. It's not what I want to do. It's not what you want to do. It's now we know what the right thing to do is. And I'm confident this is the right thing. Just don't fight with me. And that's me. All right? So, oh yeah, and that's Albert. Starts with questions and building curiosity and building the courage to question what we're doing. Because clearly what we're doing isn't the best. That's the starting point. It's like, we really don't have this down yet. We're still cutting off the wrong leg. We're still like, giving people the wrong medicine. We're still doing like all kinds of stuff that we don't really have this right yet. So. I have to give Getty images.